So I want you to imagine a bathtub, if you will, yeah? And that depth of that water is the backlog, how much work you've got in your system. The problem is you get appointments requested every day, you get your demand, yeah? And so what happens is if your bathtub's full, you've got to hope that your activity or your capacity is at least enough to keep up with it. But what tends to happen is we discover it isn't, and then of course people end up going to A&E and walk-in centres and out-of-hours centres and things like that. So what should we do? Well, there's a few things. So this is how I, and how a lot of us used to do a letter. So I used to dictate a letter and the secretary would type the letter, but she only came in Mondays and Tuesdays, our secretary. Then she'd put it in my tray, and I'd perhaps get it on Wednesday, and I'd read it and correct it, and I'd put it back in the secretary's tray, and then on the next Monday, she'd take it out, she'd correct the letter, she'd put it back in my tray, I'd sign it, because I'm good like that, but perhaps not till Wednesday, and then eventually the next week, she'd put it in the outgoing post and post the letter, and then the letter would arrive in the hospital, and that's it. Fabulous, fabulous. Can't get much more efficient than that, can you? Yeah? So what happens now? Well, we've come on. So I type a choose and book letter using a choose and book template. Then I press send, and then it arrives at the hospital. I thank you. That is it, all right? That is efficiency, that is. How much time did that save? Well, because I had to read it several times and do it, it saved me about 2 minutes. It saved our secretary 10 minutes, but for the patient, it saved them 2 weeks. Ooh, yeah, so just by changing a few little things. And this, for those of you in the know, is called process mapping, yeah? And it's all about making the number of steps in any journey as small as possible, as few as possible, and the time between any of the steps as small as possible, yeah? So these steps, whereas they used to take best part of a week to send them to the secretary and stuff, they now take a few seconds. What I'm going to do is we're going to have a few little questions here. How many days do you have to be booked ahead in your surgery for every day to be a bad day? What? Oh, genius, fantastic. What do you do? Practice manager, yes, there we go. You know the score. You only have to be booked ahead 1 day for every day to be a bad day. So it's all about getting rid of your backlog, yeah? Now, getting rid of the backlog is the easy bit. The hard bit is stopping it coming back. So how do you predict the future? Let's see how many of you can predict the future. Which is the busiest time of the day in general practice? Oh, genius! See, you're getting good at this. The vibes are coming out, aren't they? You're picking them up. So, yeah, this is the time of day, and these are the phone calls that we get into the practice wanting anything to do with the doctor. This is 2 different practices, by the way. And when I first started to see this pattern, I thought this was an artifact to begin with, this little bump in the early afternoon. And I thought this can't possibly be right, because we all know there's a huge surge in demand at the end of the day. In fact, it turns out that that is absolutely right. There is the tiniest, weeniest little surge in demand. It just seems a lot worse when you're already booked up and somebody else puts themselves on the list at the end of the day. And this, I call this the postprandial peak, yeah? Because as you'll discover from lots of things that we talk about, if people have got better things to do than call us, they'll do them. By 10:30, half the people who are going to contact you in a day will have contacted you. And by midday, 2/3 of them will. And in fact, 75% of all the ill people you're going to see that day will have contacted you by midday. Yeah? So if you break the back of the morning, the rest of the day takes care of itself. So here's another one. See how good you are at predicting the future? Which is the busiest day of the week? Which is the quietest day of the week? Thursday. Which day of the week do doctors like to work on? Thursday, yes. Oh, yes. January. Anybody else? April. Okay, why? September. We're getting a bit more woolly here, aren't we? I'm feeling it. We're getting a bit more woolly. Let's have a look. The busiest month, actually March. Anybody got an idea why that might be? Yeah, Easter has an effect. Anything else? End of the financial year. Quaff! Quaff. Quaff indeed. And what's amazing is December is actually one of the quietest months of the year. However, December is an odd one because it is a month of 3/3. Yeah. So the first bit of December, just like a normal sort of month. The second bit of December, it's like madness, isn't it? It's like Tesco on the weekend, isn't it? It is like everybody wants to get in there to shop early because we're going to be shut for most of 2018. Yeah? That's what happens on that week or so before Christmas Day. And then, apart from Christmas Eve, of course, which we've already discussed. And then what happens is Christmas, between Christmas and New Year, nobody comes. Nobody wants to be ill because they've got better things to do. Yeah? And nobody wants to be ill. So, how can I predict? Can you predict it, how busy you'll be? Well, the answer is, if you've got all of that data and you stick it into a little calculating machine, computer, I think it's called computer, then what you can do is you can actually predict. So this is a tool that we developed and we put online, and it looks at where we are now. And if things are green, it means we've got just the right number of doctors for the demand that's predicted. If it's red, it means we haven't got enough. And if it's amber, bizarrely, it means we've got too many. Yeah? So you can look at that and you can say, I can see there's a problem, but actually, when you look at it, you say that's the morning, that's the afternoon. Over the course of the day, and we'll look at some others that make it more obvious, that's going to be okay. So we're all right that week. But what about in 6 weeks' time? We've got the same number of doctors, we've got the same number of everybody, but what's changed? Well, the demand changes. And you can see now Tuesday's starting to be a bit of a problem, and these have gone green, which means that they're just about okay. But if somebody's away, you can put this into the tool as well. You can put if people are away, and you can start to see where your hotspots are. And so by being able to predict the future, you can do something about it before you arrive on the Monday morning or whatever day of the week it is, and discover you're up to your eyes in the dung beetle stuff. So let's have a look at this. This is the tool. And just to show you how accurate it is, it's designed so that 80% of the time it will predict higher than what actually happens. Yeah. So of course 20% of the time you get a higher number of calls than you'd expect, but it's nowhere near huge numbers over. So the red line is the predicted demand. This is over years. You can see it goes back to 2013 here. So the red line is the predicted demand, and the blue line is the actual demand. Yeah? Not bad, is it? Not bad. So how much patient contact time? Before we just had sessions, we were looking at sessions. This actually shows you how many hours and minutes each doctor and nurse, if you've got nurses doing this as well, will have to spend doing it. Now, we try and make it so that you have a maximum of 6 hours face-to-face or telephone time, or combination of the two, per day. And you can see the bad bit here is the Friday, where you've got 4 hours 48 per clinician in the morning and 2 hours 17 in the afternoon. Now, if you add those together, that's nearly 7 hours. Now, your decision at this point is to say, I can see that's going to be a tough old day. So are we happy as a team to work that extra hour, or do we want to get a locum to take that down? And it's about putting you back in control of it rather than it being in control of you. Because if you know you're going to work the extra, you psych yourself up. A lot of this is psychology. It's about how you prepare yourself. If you can do it for a practice, you can, of course, do it for hundreds of practices. And this is real data from, I've taken the names off, but this is a real CCG in a real place. And you can see, you can look at it and see where the hotspots are in your CCG. And not surprisingly, of course, Monday morning is a hotspot. It's a hotspot in nearly every practice Monday morning, because most buildings don't actually have enough room physically to put the number of clinicians in it to cope with the demand. So, given a free choice of appointments, what percentage of people do you think choose to book ahead? If you've got a practice where you can be seen whenever you want to? 20. When you first start, but you're absolutely quite right. By the time you've been going a few years, it goes down to about 10%. So most people, despite what you might have read or heard, most people given a free choice will choose to be seen on the day or don't care when they're seen, in which case you're better to see them on the day. Yeah? Because otherwise you're just filling your bathtub up for no reason. So how can we help more than 40% of people in less time? And so we started with a standard system, our 10-minute appointments. We looked at nurse triage. We did telephone consulting 1, which was talking to people who couldn't get an appointment when or before they wanted to, but we didn't get rid of our backlog. Then we got rid of our backlog and carried on doing that, but also talked to anybody who wanted to book ahead. And then we developed Doctor First, which is about talking to everybody. And whilst it's the most efficient way of working, it's not for everybody, I have to say. And because this one is completely demand-led, you have to have the right number of bums on seats. So even though it's 50% more efficient than a standard way of working, if you haven't got the number of doctors to do it and you don't follow the tool that tells you what's going to come around the corner, you will crash and burn. So why does it work? Well, in the standard system, you've got 18 patients in 10 minutes each. That's 3 hours worth of work. If in the Doctor First system, for example, which is the most efficient end of it, 3 people can be consulted in 10 minutes on the phone, which takes you an hour, therefore, to talk to 18 people. And only a third of those people, on average, will want to be seen. Yeah? So that's another hour's worth of seeing them face to face. So in other words, what took you 3 hours now takes you 2 hours. Or if you flip it the other way around and you say, well, we'll still do 3 hours work, what the hell I'm in anyway, yeah, you can help 27 people instead of 18 people in the same period of time. In fact, it's more efficient than that, but that just makes the maths easy. So what about A&E? How can we stop A&E being so inundated? Well, this is the King's Fund, and they said that, quite rightly, most people go to A&E during working hours, and that's remained largely unchanged for years and years and years. Yeah? And of course, that's the peak time for A&E attendance, which also, as it happens, is the time when we're all open at the surgery. People are like electricity, and they choose the path of least resistance to get whatever help they want. What happens when you start Doctor First? This is Salford Health, who found that they had a 20% reduction when they started. So why don't we all do this? Well, it's because we're afraid of being swamped, aren't we? So let's go back to our bathtub. Yeah, if we get rid of that backlog by increasing the capacity short term, yeah, then what we want to do is just end up with today's work back in the bathtub. So it's all as simple as ABCD, which is activity, backlog. Activity is how many appointments you did deliver, backlog's how many you've already got booked, capacity is how many you could deliver, and demand, which is the most difficult to measure, is how many consultations of any type are actually wanted. And we're really good at measuring activity and we're really bad at measuring true demand. Which is why when you go back and say, oh, that was our demand for last year, unless you've got a system that already operates, a system where you've got no backlog, you can't measure demand. And that's it. So what happiness is when your capacity is greater or equal to activity, and it's in balance with your demand and your backlog. And that's me done.